slides are being loaded, I'd just like to say thank you very much, Moo, and thank you very much to the organising committee for inviting me here today, and to what can only be described as the most beautiful lecture theatre I've ever been in. So thank you very much indeed. So the aim of this is really to give an overview of what we're doing in Affidea. As explained, I'm the Chief Medical and Digital Strategy Officer, but I'm also a radiologist by background. So I trained as an interventional oncology-based radiologist doing body intervention. And I moved into this company 4 years ago as the first group chief medical officer. So disclosures, first of all, I'm also on the advisory boards for IBM and for Microsoft. These are unpaid positions. And also the fact that Affidea is a for-profit company, but it doesn't take any money out of the organization. So it reinvests all the money that it makes back into growth. My other disclosure is that I'm a cartoonist, so I apologize that any pictures you see are my own work, so judge me kindly. So the idea of it is to really run through the background of where we are and what we're trying to achieve. There needs to be some foundational work before putting in AI, so I'm going to talk a little about the foundational work that we've done and also about the synergies and how we've approached deploying AI into our health system. So just a little bit of background about Affidea, because again, you may not have come across us. We are the largest provider of diagnostic imaging services in the independent sector in Europe. We, across 16 countries, have 249 centres now. We've just bought some centres in Rome. And we do around 13 million imaging examinations a year across the group. We know AI has a lot of potential, and so this is a slide actually from G saying all of the various possible benefits that AI may bring us, and that's quite clear, I think, to all of us, and especially, gone through yesterday, I think it's very clear what those benefits may be. Also, we know that AI can become in lots of areas in the workflow, again, as we've just discussed in the last talk, and my particular interest is the pixel data AI rather than the workflow data, because the workflow data will always come in the background in the systems that we buy, and I think it's the pixel level data in the first instance that's the most interesting, although it probably is the most difficult. And so how do we, as an independent company, fit into this ecosystem? So we've had amazing presentations yesterday, and the quality of the talks have been excellent in terms of the academic understanding of how to integrate and how to build these algorithms. How do we fit in? So I think we bring scale, and we bring independence. So we're able to move at a speed that's not the same as either state health systems or academic health systems. So we can be quite fast. And also we have a lot of expertise. So across the group, we directly work with around 2,500 radiologists. And we have a great strength in depth in who we have. So we have professors of neuroradiology, professors of gastroenterology, and imaging experts who form subspecialty expert groups. And we work very closely with them in defining what we do. So really, we should be the test track for new technology, because we have one platform across multiple countries to see how AI may work. And really, we should be taking the tech that's coming out of your academic centres and putting it into the real world to see what we can do and to see how it works. So in terms of operating models, this is where I kind of go businessy, and this is also where the bad cartoon starts, so I apologize. These are not the operating models which I discussed. No, the three operating models I discuss are how we approach putting AI into a system that makes sense commercially, because now I've got to have a commercial hat on as well, because not only am I the digital strategy and medical officer, I've also got to do commercial strategy for what we do. So do we just use AI that's validated, CE-marked, FDA approved, and just run with it? Do we co-create and validate non-certified AI by working with some of the startups and the spin-offs out of universities? Or do we just use the data set that we've got and annotate it and then sell the data or partner with companies to work? So there are different approaches that we could take, potentially. And they're really the three main divisions that we're looking at. But the question is where to go, because it's a big world out there. There's loads of companies going out, and how have we approached it? Because the question is, what's the objective, ultimately, to what we want to do? And so is the objective, does AI work? That's what everyone's asking here. And I'd say no. That's not my objective. I don't want to know whether AI works or not. My assumption is that AI does work. That's your job, hopefully, to develop the algorithms, get them tested, validate them, and get them through processing. That is a much more interesting question to me at the moment, which is who pays for it? Because you can do as many interesting algorithms, you can bring things onto market, but unless someone's willing to pay at the end of the day, unless there is a payer, a state or a private insurer or out-of-pocket payment, it doesn't matter what you build, no one's going to pay for it, and so no one's going to use it. And so, before we even get there, we have to have some considerations about the platform that we're on. So how do we even go about starting to implement AI in our environment? And so it's really about some building blocks, some foundations that we need in place before we go there. And so, first thing is always compliance and regulatory. And so, how do we address the thorny issue of GDPR? So, we've had quite a long process about looking at GDPR, which started around 2.5 years ago, really to work out exactly where the patient data lifecycle is in all the countries that we operate, to make sure that all the touch points with patient data we understand. So this is a diagram from one of the documents, of the reams of documents that we've produced about this topic. Then we had to go country by country and case by case, working out exactly what the country compliance regulations are. And I don't know if you can see this. So we've got all the countries that were in along the bottom. So this is a snapshot from Hungary. And then you look, so the healthcare data is on the left-hand bar, and then you go through each of the individual things. So healthcare documentation has to be stored in a mandatory way 30 years as a compliance in the country. But photography has to be stored for 10 years. Who knew? And it's different in every country. So every type of patient data has to be stored for different amounts of time in a mandatory fashion. So we have to decide how we store it, and if we do store it, when we have to remove it, and how do we comply with local regulations and such that it's transparent. So that was a big exercise we did. Also then we have to get correct patient consent. So we've got one patient consent form across the entire group. And we've got a long form consent and a short form consent. So our short form consent is consent for use. So that's just patients allowing us to process their data for clinical use. Fine. The long form consent then goes into greater detail, allowing us to anonymize the data, use it for R&D, share it with partners, and all of the other things that we may need to contact patients around. Now, of course, having a form saying I consent is not enough. We then have to have pages behind the consent form saying what we might be doing with the data. And not only that, we have to have pages behind that listing all of the people who touch your data on the way through. So these are all of the data processors, AI companies, the vendors, that sit in the background that we have to tell patients that their data is coming into contact with them. And I'd argue that if your institutions have not got this level of consent form, you're not doing it right. Because we spent a long time looking at this. And of course, there's assessment of new data processes. So every AI company or every partner we deal with, we have to look at their processes themselves, because we have to be sure that what they're doing is legitimate. And so we've got a very rigorous data processing assessment, so data protection impact assessment that we have to do. So we had a partner in AI, and we did a 3-day on-site visit to work with them, to go through all their processes to make sure it was legitimate. And not only that, we have to have monthly follow-up calls with all of our partners to make sure that they're safe and secure. So that's the regulatory piece. So that's an enormous hurdle just in itself to get to a point where we can start doing stuff. Then it comes to standardization. So again, I'm really pleased that we've got a very interesting excellence programs running across the group. So we've got 2 excellence programs called CT Dose Excellence and MR Excellence. So our Dose Excellence program it's a central program that rolls off across 12 countries so far, and it's really about standardizing the way that we do CT. So Katia, who's sitting in the front row, I'm not going to make her stand up, is responsible for this, and she's an amazing job. So we've got one process by which we acquire CT. We've got dose reference levels across the entire group, standardized. And so we know that a CT scan done of the brain in Poland is done in a similar way to a CT scan of the brain done in Portugal. We've got different vendors, different models. It's a vendor-neutral process, and we're collecting over 75,000 CT scans data per month on the system. And so we benchmark that against the DRLs, and we're able to feed back to the centers whether they're compliant and how compliant they are to standard. So I think that's an enormously powerful tool in terms of standardizing our processes. And we have a very similar way for MR Excellence as well. So again, I'm going to reference someone else in the audience. So Nikos, Papa Nicolao's brainchild is our MR Excellence Program. And Nikos developed an algorithm, an app that sits on all of our MRIs that can take off the data and the DICOM headers to demonstrate how compliant we are to standards. So we work with our expert subspecialty groups to define the MR protocols that we should be using for various indications. And then using those standards, we can again look at our image quality and look at our adherence to standard. And we can view them remotely. So we actually have an application we can view online and see how our centers are doing in real time. And it gives us not only standardization data, but also operational data, which is really helpful in terms of looking at our workflow and productivity across the countries. And if you're interested, I can show you that application later on. So at the moment, our MR Excellence Program is rolled out across 11 countries. We've connected 100 MRI scanners, and we're registering, in the last month, we registered 50,000 MR on the system with benchmarking data. And we've got 92 standardized MR protocols for body area and for indication. So again, if someone comes in for an MRI prostate query cancer, they will have the same sequences, and they've been standardized by vendor and by type of device of the vendor. So now we've got compliance, and now we've got some standardization, we need to kind of collect it. And so again, we've got a big process going on around our network. And again, this is far too big, but the bottom line is we've had a lot of thought about how we're going to connect our systems up. And the takeaway message from this is we're moving to cloud. And so we're partnering with Microsoft as our core infrastructure. And our infrastructure is based in Microsoft Azure Cloud, so we're migrating everything there. And our PACS is fully web-based, and it's run out of Azure. So now we can deploy our PACS. So if we go into a new center, for instance, so if we buy 3 centers in Rome, as we did last week, we can deploy our PACS and our RIS platforms remotely so they can be up and running immediately in a secure environment. So it allows them to connect into the network in a seamless fashion. So going back to the operating models. So now we've got compliance, we know we've got some standardization in what we do, and we've got the network in place. So how do we go about actually looking at what we do in terms of AI? So we first of all went with number 1, because it was not the most straightforward, but it was the easiest, we think, to demonstrate value. Because now with my Chief Medical and Digital Strategy Officer hat, and I'm sitting at the board, and I'm having to make a case for investment to the board members to say, we need to do AI. And so we thought this was the best route that we can demonstrate value creation. So first of all, then, we have to select the AIs. So we've got a selection criteria, the first one being it has to be valid for us to use as a medical device in Europe. So it has to be CE-marked, we have to address a common entity, we have to think that it's going to make sense in terms of, will a payer pay for it? Can we create something with it which is a product? And is it compatible with our infrastructure? And can it be embedded in the clinical workflow? Now, the bottom point is very interesting. So the 4-stay capital. So Affidea is wholly owned by a family fund called Waypoint Capital, which is a family fund of the Bertrelli family. And they're very interested in life science and health tech. And so they wholly own us, and that's why they can afford to have infrastructure and be interesting. A partner company, or a partner strand within Waypoint Capital, is 4-stay capital, which is an early tech venture fund. And so there's an interesting synergy here, because if we identify interesting AI or interesting companies that we want to embed in our network, they can simultaneously invest in them. And then by us rolling them out across Europe, they then gain value. So it's an interesting synergy on a business side. So we then had to select our AI. And so over the last RSNA and ECR and all the meetings, we then had to classify all the AI by those criteria. So this is one page of about 20 AI companies that we then had to classify and determine which ones we should go for first. So we then need to create a pipeline. And then we need a project to actually then how we approach rollout. So we say, okay, now we've selected our number 1 target. Now we're going to say, right, across our group, across our 249 centers, which centers will be applicable to roll out this AI in? Where have we got the center of expertise? Where have we got the compatible machinery that will acquire the imaging? Where have we got the right team? Because again, this is so much team-based. We need a real, there needs to be great education, which we're going to talk about later. There needs to be good infrastructure. There needs to be a willingness to engage on the behalf of the radiologists and the radiographers. We need to have the right legal framework locally, regulatory, digital. We need to define what our KPIs are. One of those being financial. So can we put more work through as a result of the AI? Are we doing more work at the end of the process than we are at the beginning? Can we charge more? Can we charge our payers more for it at the end? How do we market it? How do we build it? And finally, how do we train our staff on the ground? And so our first target was icometrics. So you may have come across icometrics. It's a brain AI imaging AI company based out of Leuven, and they're interested in multiple sclerosis. Sorry, not cancer, but of the 4 AI applications in our pipeline, 2 are oncology-based and 2 are non-oncology. And our first one happens to be non-oncology, so forgive me. So this happens to be multiple sclerosis. And icometrics basically do a quantitative algorithm that segments the brain and it looks at deep white matter lesions, and it can look at change over time in a way that's superhuman. So radiologists cannot attain this level of detail. It's CE-marked, and so we developed a product. So our product is the Affidare NeuroInsight product based upon icometrics. And then we're rolling it out across 4 countries in 6 centers simultaneously. So we've got a program of rollout that looks the same across all the countries using the same infrastructure, with the idea to gather the KPIs over 6 months and look at the business case and look at the models. Because the fascinating thing for me, coming from one state health system in one country into an environment of 16 health systems where we've got different provider and payer models, is that no one size will fit all. And so any one AI company is coming up saying, we're going to sell it for this much, is nonsense. Because they'll never sell one app in Serbia for the same they'll sell it for in Switzerland. It's just different models. So we need to work very carefully about looking at, again, interesting AI companies coming to us because we give them unprecedented market access, because we allow them to deploy in a country and test it. So there's a great benefit for coming into our test track. And as we're deploying icometrics, Forstay have invested. So Forstay have been the lead investor on their latest fundraising round of 18 million euros. And so they've been the lead investor in that round. So, to conclude, I think this is the first standardized multi-country deployment of AI in clinical practice. I think, I don't know, tell me if I'm wrong. And we have a pipeline in place of 3 further AI which are coming on board in the next 3 months. But we've got a cadence now, we've got an understanding, we've done the background, we kind of know how it's running, and each of them have got different KPIs. So we'll see as they roll out what happens. And we'll see at the end of the year what the results are, because at the end of the day, if it doesn't make sense financially, we can't do it. And that's the message I give back to the AI companies, is it has to be a compelling business proposition, because someone's going to have to pay for it at the end of the day. And of course, the 2 other business models are being explored as well. So I'm only looking at number 1 here. The 2 other business models about data collection and co-creation are still there to be explored. And we're looking at those in parallel. But that's, again, that's another lecture completely. So, in conclusion, I'd like to thank you very much for your attention. And if there's any questions you have at the end, I'll be very pleased to ask.
Thank you for that. Moving a little bit forward, we heard about, software design, hardware integration, healthcare integration. And now it's a great pleasure that I'd like to welcome to the podium Dr. Nicola Strickland, who is the president of the Royal College of Radiology in the United Kingdom. And we've asked Nicola to specifically, from her perspective, as president for a number of years now, to share with us a vision about training the workforce, opportunities, and challenges. Nicola.
Well, thank you very much. Good morning, ladies and gentlemen. Thank you for inviting me here today. So in addressing the issue that I've been given here, artificial intelligence training the workforce, opportunities and challenges, I thought we should first consider who is the workforce. So I've listed what I consider to be the main workforce here, which needs training. So that ranges from medical students through trainee radiologists and indeed qualified radiologists, because those of us who qualified some years ago were not brought into contact with AI or machine learning during our training. Many other doctors. This is not a domain that is exclusive to radiology by any means. And also, I've put in there computer scientists. Well, I'm not trying to suggest that they need training in AI as such, but what I mean by that is that we as doctors need to collaborate with clinical scientists very closely. In particular, to collaborate with issues that are clinically relevant, so that we work as a team and relevant issues are addressed by the basic scientists, and that those projects, if you like, are well defined. So for me, having been involved with the inception of PACS more than 25 years ago, it's a very similar scenario. We must, as clinicians, get ourselves involved right in there with those who are developing machine learning algorithms and work as a team and collaborate right from the start so that we are producing software that is actually relevant to clinical practice. So when it comes to training, what do we mean by training? Well, I thought I'd just mention what I don't mean by training to start with. And what I don't mean is actually physically clicking on an icon or a button to activate the AI software. Obviously, that will need to be done. One will need to make sure that in many cases, the AI software is integrated between the data acquisition device, the CT scanner or whatever, and the PACS workstation, but I'm not addressing that. And what I'm actually taking for granted is that there is good integration of the AI algorithm when it's ready for use into workflow. Now, that is a big taking it for granted, and it is absolutely essential that that be the case. Whether we're talking about radiology and integration into the radiological information systems and PACS, the RISs and the PACS and the electronic patient record, or whether we're talking about working in the clinic or in a general practice setting, especially when we're dealing with a full gamut of genomic profile data being available, which shouldn't be too far away, but it needs to be available integrated, and with the electronic patient record data. So what I do mean by training, actually, is empowering. That's what I mean by training. I mean empowering users to know what they are using. In other words, is the AI they're being asked to use fit for purpose? And more importantly, how do they as doctors and radiologists judge whether that AI is fit for purpose? So you might think, well, why is all this necessary? Why is it necessary for doctors to be empowered in this way? Well, it's partly because the regulation of AI is currently inadequate. And it is actually, of course, that regulation is very difficult to perform at a national or international level for all sorts of reasons, which we'll touch upon. And also because AI products are perhaps in many cases being prematurely entered into clinical practice. So why is there this pressure to introduce products prematurely without rigorous testing into clinical practice? Well, there's a whole lot of reasons, but in the UK particularly, it's because of a huge shortage of radiologists leading to a workforce crisis. So in fact, we have more than 10% of our consultant radiology workforce, staff posts, unfilled. In fact, 2/3 of those unfilled for over a year. Not, I might say, because radiology isn't one of the most popular specialties to go into, it is, but because the government of England and the devolved nation healthcare systems, in their wisdom, will not fund enough trainee posts for the radiologists we need. But that's a bit of another story. We also know that there's a hugely escalating workforce everywhere, about 10% increase in CT and MR scanning year on year. And that has left us in the UK with, at any one time, 250,000 imaging studies waiting over a month to get a report, which is just unacceptable at a patient level. So we are looking, obviously, there is pressure to introduce AI to address that workflow deficiency by improving the workflow efficiency, particularly, as we've heard, the speed and the accuracy of that workflow if possible. Yes, we do want to remove the repetitive drudgery that as radiologists we don't want to be involving ourselves with if we don't have to, if we can get our software to do it for us, particularly as screening increases, putting resist measurements and so forth, volumetric measurements, if that can be done automatically for us, we would welcome it. We know that we want to work towards personalized medicine, and I think that is really something that's the most exciting area of AI and machine learning, but I don't realistically see that coming into our routine clinical practice for about 10 to 15 years. What we do hope that machine learning will allow us to do is to work more as clinical doctors again, to free up our time so that as radiologists we can interact more with patients and we will have more patient time. And then, of course, there's the whole issue of financial gain. Financial gain, obviously, to the vendors, which we've heard about, that needs to be the case, or there's no motivation. And, of course, for the hospitals, if they can replace or at least fill those vacancies with software that doesn't need to be paid holiday, study leave, pensions, sickness pay, and can work 24/7, so much the better for hospital management. We could perhaps make some comparisons with other products that we use in our everyday lives. And you could argue, well, actually, we use many things, including, fridges or perhaps even our MR machines or our laptop computers, where we don't, as doctors, fully understand necessarily or remember from our school physics exactly how those work. But it doesn't stop us from using them in our everyday lives to our own benefit and the benefit of others. But of course, those products don't actually evolve whilst in use. So that is one big area where they're very much unlike any kind of artificial intelligence. And then if we take the whole area of new drugs, there is really no comparison with the kind of regulation that's going on or not going on with AI software and the very rigorous, really, testing of new drugs before they come into clinical use. So by law, there must be a product license that comes from a medicines regulator before going onto the market in the UK. That's the MHRA, the Medicines and Healthcare Products Regulatory Agency. And there you have trained MRA assessors who review all the available evidence from preclinical trials and from clinical trials before the drug would be considered to be brought onto market. And there's, of course, the inspection process as well of the manufacturing. In the factory, are the supplies uniform? Are they of high standard and produced to that standard routinely? So in terms of the problems with AI regulation, why do I believe that it is currently inadequate? Well, there are a lot of reasons. There is a lack of rigor in the regulatory testing. And the more I get involved with this, the more I'm concerned by what there is out there, really. So we are seeing AI algorithms coming to market with a CE mark or indeed with an FDA approval without actually having been independently tested and without any publication in some cases in peer-reviewed literature. There are, as you will have heard yesterday and earlier today, huge problems associated with the testing process, particularly in terms of the data, its amount, the access to those data, and the quality of those data. The resource needed actually to do that rigorous testing, and of course the workforce needed to do it, because that workforce will actually need to be paid to do it. And then there's the whole issue about AI/ML spectrum of continuous learning. So are we just going to be dealing with, as we have up to now with the FDA-approved products, with a locked algorithm that's been tested at a certain stage and isn't allowed to develop further in clinical practice? Or are we going to allow it to be an adaptive algorithm as it's designed to be, which will mean it's evolving all the time, hopefully improving all the time, but for all we know as doctors, it could actually be getting worse. So we need to have that regulatory process in there. So in the UK and in Europe, we rely on the MHRA, but there is a definite lack of clarity about how they are testing this software. Certainly AI in the UK is classified as a device. Software is classified as a device, and in the EU medical devices regulations, which actually were produced in 2017 but don't legally come into force until next year, AI software is mentioned as an active device. Software is mostly class 1, but AI software is mostly class 2A because that affects the diagnosis out of 3 classes, I should say, class 3 being something like an aortic stent or a valve that could whiz off and kill you if it was faulty in some way. The CE mark, the Conformité Européenne, is adopted in the UK. We are, of course, still in Europe. And the MHRA works with notified bodies, which I didn't know too much about until recently, but they can be from anywhere in Europe, and their function is to approve these AI algorithms. But in fact, it turns out that the AI algorithms themselves don't have to be tested as such by the notified bodies, but the notified bodies do have responsibility for looking at the controls and the clinical governance that's in place in those companies to make sure that those are rigorous, but they don't necessarily have to test out the AI algorithm. Now, in the United States, in April of this year, they published this proposed regulatory framework for modifications to AI intelligence and machine learning. And I think that's very positive. It's out for consultation. It's positive because they are working in a framework which the UK needs to join and Europe needs to join of the International Medical Device Regulators Forum. They have 4 classes that they have defined there, depending on how critical the software is and what its function is. And they've also devised this cycle, this sort of product lifestyle regulatory approach, which is promising in that it takes on board reviewing the AI software, the specifications, the pre-specifications, and the fact that these algorithms can change whilst in use. And it also takes into account real-world performance monitoring. So these are positive developments, but they're out for consultation. They're not actually in force at the moment. The clinical evaluation components that are described by the IMDRF, I've put up there are 3 of them. So just working through those. First of all, valid clinical association. So here we're asking, is there a valid clinical association between your AI software output and your AI software's targeted clinical conditions? So here, what we're really saying is, does this little spiculated nodule really, which we as doctors, as radiologists would say had a high probability of being a lung cancer in a screening population, for example, do we know that really does genuinely represent a lung cancer rather than, I don't know, a tuberculous lesion, for example? Is it likely to be a lung cancer, and is this triangular shaped lesion adjacent to a fissure highly likely and proven to be an intrapulmonary lymph node in the vast majority of cases? So here we're asking, is the question, the AI software question we're being asked, really clinically relevant, and is it clinically accurate? And that is all relating to the input data quality. So this is the bit where we as doctors need to be working with clinical scientists, computer engineers, to say, are we developing things that are relevant and doable in clinical practice? Just in the same way that we originally needed to work with the computer engineers when we were developing PACS and PACS software, was the PACS software relevant to our clinical use? Did it allow us to use all those data in a relevant and efficient way? So then the next category, analytical validation, is really asking, does your AI software correctly process the input data to generate accurate, reliable, and precise output data? So in other words, when it's presented with a small lesion, which is subpleural, it's polygonal, it has little flanges associated with it, is it likely to say that is an intrapulmonary lymph node? So this is really the validation data and the testing data, and what is the accuracy of that? What are the false positive rate? What is the false negative rate? And is this clinically true when you, as a radiologist in your department, in your area of the world, use it? And then the third category, clinical validation, does the use of your AI software's accurate, reliable, and precise output data achieve your intended purpose in your target population in the context of clinical care? So supposing an algorithm for looking at lung nodules, this lung nodule here, sitting next to the oblique fissure in sagittal plane, had been developed in, say, Lisbon, for example, do I know that when presented with a similar lesion, polygonal on a fissure, in my, say, home population in, for example, Manchester in the UK, is it going to come to the same conclusion that it is an intrapulmonary lymph node? So obviously that depends on the training data and the diversity of those training data. And here we're really asking, does it work on your population of patients? That, as radiologists, is what we want to know. And so what I'm really saying is that it's these two questions that I think that radiologists need to be empowered to be able to test and to understand. So how can we empower them? How can we equip radiologists to judge the AI software that they may well be being asked to use by their medical director that may have been purchased for their institution? Well, firstly, as I've said, I think it's very important that we do introduce some AI and machine learning training into medical schools and certainly into the FRCR curricula. That's our board's exam. And you'll be pleased to know, the British radiologists amongst you, that I have managed to get AI machine learning as core. We're rewriting the curriculum, which will go to the General Medical Council in the summer, and that has been introduced as a core subject, and we now need to define what sorts of things our trainee radiologists need to learn. And I think they just need to learn an understanding of the terms and methodology we're talking about, have a basic knowledge of statistics as well. I'm not saying an in-depth degree in statistics, I'm saying things like understanding about ROC curves and output curves and DICE indices and so forth, and understanding the challenges, all those challenges with the data, which we'll come back to, that have been talked about yesterday and today. They need to understand that publication in peer-reviewed scientific literature is important, and how can they, as jobbing radiologists and doctors, actually judge this. So it's not just being fooled by presentations at conferences like this, which are relatively easy to justify AI software at a conference or a promotion, for example, but much less easy to justify it in a properly peer-reviewed paper, which will allow rigorous assessment of the software development process and repeating of that process by other groups. Radiologists must know, and other doctors must know, how the algorithm was developed. And I'm talking in broad terms only. I'm not saying they have to understand the intricacies of convolutional neural networks or random forests or whatever, but they need a concept of what we're talking about and how that was derived. And to understand about the data used to train the algorithm, the numbers needed, the provenance of those data, and the same for the data used to validate the algorithm and to test the algorithm, and to understand terms like the accuracy of the algorithm, the true negative rate and true positive rate, and how those functions were actually measured. And so I'm arguing that in training, radiologists and other doctors need to know how to set up their own clinical study to judge AI, the AI that is being introduced into clinical practice that they may well be being asked to use even now. And to know an appropriate methodology for a study, hopefully done on a multi-site basis, to have an understanding of statistical powers, a number of studies they need to look at and to assess in a randomized double-blind fashion and so forth. You could say, well, why bother? Why should doctors bother with this? And of course, they could say, and I've heard general practitioners say, well, we've been asked to use this diagnostic app, but frankly, I don't think it's coming up with the sort of diagnoses that I would normally make, so I'm not using it because I don't trust it. But how much more powerful are those arguments if we, as doctors, have actually got the evidence to say, look, we have actually looked at this in our practice, and these are our meaningful results. That gives us credibility. That gives us a strength of argument. It even would enable us to, if we were sufficiently worried for our patients, to halt the premature introduction of AI or ML into clinical practice. And of course, at our heart, we're interested in patient welfare. And we're also interested in personal medico-legal safeguards if we are using software that we don't believe is fit for purpose. So when it comes to data quality, I apologize profusely. I was very sad that I wasn't able to be here yesterday because I had Royal College commitments, but I know that you will have talked yesterday about data quality, and you will have heard from Professor Rockel about the importance of the training data from which the task-specific features are learned, and it should be similar to the unseen test data. And the point here was made in this group's publication that you do need large amounts of data for separate training, validating, and testing cohorts, as we all know. And those data need to be homogeneous. So homogeneous, as we've heard repeatedly, in terms of slice width, for example, the protocol that was used, was contrast used, what sequences were used, and the previous speaker has just highlighted how that can be theoretically standardized in different centers in Europe. But it is a major undertaking, and we're certainly not there yet in the majority of centers. I'm sure that the example may well have been given from that paper, and it is very pertinent that even in that whole body MR study, which supposedly has got the same sort of data being collected, there are all sorts of inhomogeneities. So the whole body in some centers is defined as neck to knees, and in others from top of head to below knee. There may well be chunks of data actually missing, as in the neck here. There may be a radiofrequency artifact in the data. There may be a breathing artifact, and so on. So all sorts of complexities, and it's those kinds of complexities that I'm arguing that in their training, radiologists and other doctors need to appreciate. Then when it comes to data quantity and access, well, I've said data are the new gold. You could say it's the new oil. It doesn't really matter, but the point is it's a very valuable resource. And in fact, the UK, which was the first fully, entirely paxed, if I can use that verb, country in the world, all those paxed data are largely being wasted. Why? Well, because there's no anonymous national database. And in the UK, what is the actual motivation for individual radiologists or sites building up such a database? What are the logistics? Of course, they would be huge to build that up, and the cost of it. And another big blocking factor for building up any national archive, actually, is the fact that integrating the healthcare enterprise TCE profile, the teaching file and clinical trial export profile, although it's been in existence for several years, has actually only been activated, only been implemented by 2 or 3 PACS companies throughout the world. So it's actually very difficult and clunky for us to submit data while we're sitting in front of our PACS workstations, such that by a single click it'll be anonymized through the firewall and go somewhere else or go to the cloud or whatever. So what is happening is generally a lot of the access to hospital data is happening behind firewalls, and that is an inequitable situation to be in, really. It's unfair in that large companies can obviously come to institutions, large institutions, say, okay, we will pay to use your data. You will benefit by either being paid or by getting the spin-off of having a fantastic algorithm that we're going to develop, and you'll get it for free or whatever. But it discriminates in favor of big companies. And of course, we will have heard a lot about the need to access anonymized or robustly pseudo-anonymized data. And in the UK, certainly, that actually can be used without consent, and that is in the Caldicott guidelines, and I have personally verified that, spoken to Dame Fiona Caldicott and verified that that is the case. But there is still ethical unease in the UK about that, and there's certainly a very marked lack of ethical guidance in many of the lower and middle income countries, and in India and China, for example, where it's possible and people are buying huge amounts of non-anonymized data to use in developing AI algorithms. So you will have heard yesterday, I'm sure, from Professor Pryor. His group have developed this large cancer imaging archive. And he has stressed to you the need for large, highly quality-based data sets where curation really is the key to quality, which should be publicly accessible according to those FAIR principles outlined there. Just providing you with some examples, really, of the challenges and all these, as I say, radiologists and doctors need to be aware of in their training. Peer-reviewed publication, I mentioned the importance of that to us as doctors and radiologists. And I think, for me anyway, as a clinician, the work that was done at Moorfields Eye Hospital in London, published in Nature Medicine on retinal scans, the optical coherence tomography work, is anyway really quite a good example of an exemplar of a really large study which was described and illustrated in a way that doctors can understand. So the OCT data will put out alongside the manual segmentation, the automated segmentation, the correlation between them, the fact that this was a huge data set, really, by most standards, nearly 15,000 scans. The data were cleaned and curated. There was a 94% accuracy rate. It was looked at by 8 neuro-ophthalmologists. And so they also found that this AI technology can be applied to different types of eye scanners that they used in the hospital, so it was actually vendor independent. Admittedly, only for Moorfields patients at the current time, but nevertheless, if any of you have had the misfortune to sit in an optic outpatients, as I have, for the many hours it takes to get your OCT processed, then you'd be very grateful for any valuable AI algorithm that can actually ameliorate that process. So I'm just using this as an example of some published literature which does appear to act as a bit of an exemplar for us. And that is not true for all the software that has been given CE or FDA approval. I'm not trying to pick on any one company particularly, but there is this software from Viz.ai, thrombotic stroke detection alert, whereby the scanner data is analysed and the pertinent clinician, the stroke physician or the neurointerventionist phoned up if there is a strong suspicion of thrombotic stroke, which could be acted upon quickly with mechanical thrombectomy. And that has been introduced into clinical practice, and I have been told that a lot of unnecessary phone calls are being made to clinicians telling them about thrombotic strokes, which actually aren't thrombotic strokes when the data are looked at properly. But I haven't been able to find anything in the peer-reviewed literature on that particular software, and it was only analysed, according to the company, by 2 neuroradiologists on 300 CT scans, and yet it is approved by the regulatory authorities. So other examples, well, it's interesting, of course, that we do have an adaptive algorithm in clinical practice that we're all very happy with as radiologists, and we've been using it for 20 years, which is speech recognition, which is a form of machine learning. It is seamlessly integrated into the clinical radiological workflow. It continues to learn whilst it's in use. We accept a 5% error rate. And why are we so happy with it? Well, because we have control over it. We take responsibility for continuing to train it. So, if you have a report on this case of sarcoidosis, for example, as the radiologist reporting that, it's up to you to correct those data or to correct the output, and thereby the learning algorithm progresses as it goes along. Yes, you may lack a classical education and not know that hilum is second declension neuter Latin and that the plural is hyla, and therefore you may correct it wrongly, or you may not be a native English speaker and therefore your report may not be as perfect English as one might hope. But nevertheless, no patient is damaged. And therefore, it's not an issue of harm to patients, and we are perfectly happy to use that particular example of AI in our everyday practice. There are other examples, understanding the relevance of how we're judging this offer is important to clinicians. So if you take the automated contouring of the left ventricle and the right ventricle in cardiac MR, for example, which didn't exist when I originally, I'm not a cardiac radiologist now, but originally I introduced cardiac MR to the Hammersmith Hospital in London, and believe me, I've spent many hours tracing around the endocardium of the left and right ventricles. So obviously, for us to know as radiologists that this sort of software, which learns by transfer learning of being able to produce an accurate automatic outline of the left and right ventricles, has a high DICE index of 0.9, the DICE index being comparing the AI contour with the expertly drawn contour. That's important. That enables us to understand how to use that particular software and its value. So in conclusion about AI training and the workforce, the opportunities and challenges, I think that I hope I've shown you by some examples of how the workforce actually needs to be trained, what sorts of things we need to know about as doctors and medical students and radiologists. And I think there are many opportunities here. I think, first of all, we must change our own mindset and realize that just as with the early days in PACS, we as clinicians need to influence the AI development and regulation and work very closely with computer scientists and engineers. We need to understand the challenges that are being faced here and regard those challenges actually as opportunities. So we need to know about the types of data, the data requirement issues, the quality, the access, the quantity of those data. We need to know about the limitations of the regulation and the regulatory requirements, and to get involved with the monitoring and the implementation of that regulation. So I'm on the expert working panel of the MHRA, and we'll be encouraging them to work with the FDA and the international body in order to take that forward, and having the consequences of adaptive algorithms. So we need to empower ourselves, we need to remain involved, and we need to use AI and ML to augment our work and to help patients. So I think we must welcome AI because it helps us and it helps patients. So thank you very much indeed. Thank you.